Thank you, thank you, Dr. Meyer, for the invitation, and it's a great honor for me to be here. As you said, we have very special link between our two services, and I must say it's also a pleasure to be here. Oh, there. Give me a few seconds. We have. I must say it's also. Can you hear me properly?
Yes, there is some echo, but I can.
No, why?
I would like to ask all the attendants to mute their micro to avoid interferences, please.
Sí.
Okay. So my link to Argentina, of course, is, as Dr. Meyer said, my first link and my most important link right now is probably Dr. Giacone. We had the privilege to have Dr. Giacone for almost 2 years in the service, and he was a fantastic addition for us. We learned a lot from him, and I hope he learned something from us. But it was great to have his point of view, and so this was my first thing. But I have also 2 childhood idols. Of course, Diego Maradona was always in my room, in my childhood's room, and Guillermo Vilas also. So these were my links with Argentina. Later, I discovered Jose Luis Borges, but this was really my link for Argentina, and it was always something special for me. So coming back to our topics, the history of breast implant began in the 60s with the first generation of breast implants described by Cronin. These were silicone implants with a huge amount of leaks. So a lot of those silicone were leaking outside the implant, and a lot of drawback occurred because of that. So in the 70s, the same companies began to work on a more stable implant with less leak. This was the second generation of Dow Cronin, but it was still problematic with a lot of capsular contracture. And you all know the problem of capsular contracture and the concern we have for this problem in our daily practice. Fourth generation. The major addition in this fourth generation was that they added a silicone layer, a rigid silicone layer that prevented some kind of links. So we had in the pocket, in the silicone pocket, we had 3 layers, and the more superficial layers was separate from the 2 others. So this was very interesting because this allowed the companies to work on the surface texture on the implant. So for the first time in the 90s, we began to see work on the surface of the implant. The company began to advertise that they had different surface, and each surface was better than another. So we had a lot of work on this surface implant. So for long, and since the beginning of breast implants, the problem was capsular contracture. This was the major problem. They work on silicone, they work on surgical technique, but the companies work on surface morphology, and the morphology really of the implant began to change. And this is where I began my career as a researcher in Paris, and we wanted to see if all those implants that were proposed by the companies were different one to another. So we just asked the companies to send us some implants, and they send us some samples, and we just studied the surface of the samples. And at the time, we were able to study 7 of those samples with 7 different textures. And this was our first paper, and we were surprised because nothing was written at the time on the difference between the different surface implants. And we discovered that actually it was very different one to another. Very different one to another. And then we discovered that the way these implants were manufactured were very different from a company to another. So this was the first paper just to assess that we had different surface and that we had nothing common between a microcell, a mentor, and a biocell implant, which was manufactured at the time by Megan, later by Allergan, and mentor at the Siltex texture, which is still on the market. So this was the first paper that we made. All these different textures, do they have an effect on the capsule? So this was the second question. We had several textures, and we wanted to know if there were a different response in the body. So we had to go back to the patient and to harvest some piece of capsule for each kind of implant. And this was the theme of our second paper. And we discovered that almost all the so-called texture implant were acting like smooth implant. So we had nothing different in the capsule in most of the texture implant, except one, except the macro texture implant. And this was the third paper we published. So the macro texture implant, some pore, so it was the biocell. So it is now manufactured by Allergan. And this implant had pores that were deep enough to create an answer, a response by the capsule. And we were able to prove on several patients that the response was quite identical, that the capsule was identical, the identical mirror image of the implant, of the surface implant. So in this case, we called it the Velcro effect. The Velcro effect for us as for goal to stabilize the time when I published this paper, the company came to me. So they came to me from California, and we began to work together because they were very interested that we discovered that and that it could stabilize the implant. So they began to work on different shape of implant because the implant is stable on the pocket. We can shape the implant and you can give a shape to the implant. And we began to believe that this was really the holy grail, that this was what we wanted. So we also had several publications at the time showing that we were reducing the capsular contracture drastically by five times. And also that we could have an atomic implant. So I was doing some work for the company, so for Megan, then from Allergan, and we were presenting this implant as the ultimate implant, as the new technology that had solved all the problem of implants. But very early, some problem occurred. So when I was doing those meetings, I was doing my speech exactly what I told you right now. And people after the meeting were coming to me and were telling me, "Oh, I have problem with those implants. I have some of those implants are turning upside down, and I cannot control that. I cannot control those implants." So this was coming coming, and this was also going to the company. At the same time, the company began to receive a lot of complaints about those specific implants, macro texture implants. And then came in the early 2000, then came the first cases of BIA-LCL. So the Australian and the MD Anderson team began to publish extensively about those problems that we knew about. We knew that it was possible because we knew about those macro-texture implants. But this changed completely the game, because at this point we had a disease that could be lethal to the patient, to aesthetic patient, and this was not acceptable by the market. So it was rare, but it was there. So we had to deal with it. So the main problem in those macro texture implants is that we didn't all share the same results. So we had to find what was the problem, because there were a problem among very talented and very gifted surgeons that were not able to achieve goals with these implants. So first we work on double capsule. Capsule was the first thing to elucidate. We must understand how it happens. So with Allergan, we did a study putting this implant on the shoulder of a sheep. And then we realized when we put the implant on the shoulder of a sheep, that the sheep is always moving, and that we had 100% of double capsule. So it was clear for us that there were a link between the movement and the creation of double capsules. So then, in the same idea, in the same theme, I had an experimental model, a live in vivo experimental model that I wanted to use. That was the expander, because the expander you will feel, so that you will move. And in my team, I had at the time people who were moving, who were inflating the implant very quickly after 1 or 2 weeks, and people who waited like me 6 weeks before inflating the implant. So we were able to create 2 groups of patients. One group was the early inflation of the implant, and the second group was the late inflation of the implant. And what we proved in this paper that was published in the PRS, that when we were inflating the expander early, we were creating a huge amount of double capsule, clinical double capsule, and also scanning electronic microscopy double capsule, as you can see below. So the group where we were waiting 6 weeks before inflating the implant, we were able to create this mirror image on the capsule, and we were able to give stability to the implant. And again, we had this mirror image between the implant and the capsule. So then we moved to a more global understanding of double capsule. And this was published not in Plastic Surgery, but in a general scientific journal, very high impact factor. And we were able to publish that because they at the time, they understood that it was more than about aesthetic, and it was more than about plastic, but it was really about biomaterials. So we decided to study separately the capsule. So we selected the case of the double capsule, and in those cases, we removed the capsule en bloc, and then we peeled each side of the capsule. So at the time, we were able to study each side of the capsule. So in this study, we began to study the inner side of the double capsule. And the inner side of the double capsule was reacting like a stable capsule in macrotexture implant. So we were having this mirror image again. And when we moved to histology, we were able to see that we had this creation, this tissuing grow into the pore of the implant. Like a mushroom that is going inside of the implant. And these mushrooms were oriented rightly to stabilize the implant in those cases that have double capsule. But when we looked at the inner side, we were able to see that the process was the same. When we took those double capsule laterally, we began to find some fracture in the capsule. So we took several samples. The first sample was on the dome. The second sample was lateral on the rib. And on the lateral sample, on all the lateral samples, we were able to see some fracture inside the outer aspect of the inner capsule. It was smooth, perfectly smooth. And the outer capsule itself was perfectly smooth. So then we wanted to study the intracapsular space. So what was happening between those two capsules? Because for most of the case, those patients were not symptomatic. So we were finding those double capsules when we were removing the expander, but all those patients were not symptomatic. So we study the inner capsule, intracapsule space. So so studying this, we saw that we were able to see all the different steps of the biofilm. So very few spots of bacteria. Then we had the full coverage of the biofilm. And then we have the biofilm almost ready to explode and to diffuse the bacteria in the space. So we had all those space in asymptomatic patients. And when we moved on the implant itself, we're able to see that on the side that was, on the capsular side that was directly connected to the implant, we had really a lot of bacteria growing up. So not at the point to be moving to the intracapsular space, but enough to be a quiescent bomb that can explode and plate seroma. So this image was taken in many papers later because in asymptomatic patient, in a normal patient, we're able to demonstrate that you have a good amount of bacteria that is present on the capsule. And these bacteria were of various type, of various size, and most of them were from the skin. So most of those bacteria were not coming from the breast, from the canal duct. They were coming from the skin at the time of the insertion of the implant. So this was also very interesting because for years we were sure that we were putting the implant the right way and we were doing our best to having some bacteria on the surface of the implant and then on the surface of the capsule growing into that pore. So we published several papers about the repartition of the bacteria, the bacterial load between the different sites, the capsular the protease interface, the intracapsular space, and we could see that we had not the same amount of bacteria, and that most of the bacterial load was near the implant, was coming from the implant actually. So in the conclusion of that paper in biomaterial, we explained that for us, it was the load of bacteria. The load of bacteria was coming from the insertion of the implant. Most of the time, this was asymptomatic. So we won't see anything clinical about this load of bacteria. But in macrotexture implant, on the lateral side of the implant, the Velcro effect was creating some fracture inside the capsule. So we were creating the mechanical delamination was linked with mechanical movement of the top of the chest. So we had two phenomena, the double capsule, and at the same time, on the implant side, you had some bacterial load. And for some reason, at one point, the bacterial load is exploding in the intracapsular space, and it's creating these clinical late seromas. So this was our hypothesis, and I think now most of the authors agree with us that this is probably part of the phenomenon. So we have some disagreement with some teams, but most agree that the bacterial load is coming from the implant itself. So another topic I wanted to share with you was the revolution we had in North America about ADM, acellular dermal matrix, and about the genetic part of breast cancer. This creates a huge and prophylactic mastectomy drove us to keep the nipple areola complex entirely. You can see this is a before and after. So you can achieve very good results, very natural results for those patients that don't have any breast cancer, but you need to add this acellular dermal matrix. And now the selling of this acellular dermal matrix in North America and in our hospital is higher than the selling of breast implant itself. So we are using more acellular dermal matrix than we are using implants. And for the company, the production of is than the production of breast implant. So this is a huge shift. So for a new device, the cellular dermal matrix became in North America, we are using it almost daily, on a daily basis. So we had to study what happened with the capsule and with the different implants in those situations. So we did the same type of study. We studied the capsule using the expander model. We were able to study the capsule on the muscular side here and on the acellular dermal matrix side. So at the time of removal of the expander, we harvest a piece of capsule on both of this side, and we study these different capsules. Front of the acellular dermal matrix, there is no ingrowth of tissue in the pore of the capsule. So there is absolutely no ingrowth of tissue in the implant. Can you hear me?
Yes, we can hear you.
Okay, so we had, in all cases, a huge biofilm in front of acellular dermal matrix when we were using those macrotexture implants. So even if when we use a new device, you have really to test this new device in different conditions, because we were using at the time this new device with microtexture implant. Even in my service, I was the one who published the study about velcro effect, about double capsule, but we were still using the microtexture implant. Paper, it was 5 years ago, that we had a huge load of biofilm in front of alloderm when we were using those implants with all the step of biofilm. So we began to ban the macrotexture implant when we were doing this prophylactic mastectomy and when we were using this kind of device together. And when we moved to the pore of the implant, so this is an implant pore in front of an alloderm, and you can see that it's full of bacteria. So it's completely loaded with bacteria. So we had those patients with alloderm, macrotexture implant, and it's like having a bomb inside your body. At one point, you have this huge load of bacteria, this huge load of biofilm, and you can anything else, it can explode. It can create problems. So we then wanted to know, because when we began to use the acellular derma matrix, and I'm not sure if you're using it in Argentina, but here it became huge, and we had some problem with some patient that had a rest breast syndrome. So the rest breast syndrome was described by Slavin, and Slavin is a huge guy from Harvard University, and they describe it as a delayed type hypersensitivity. So they were sure we had to treat those patients with corticosteroid. So this was the trend. So we're having this red breast syndrome. It's approximately with those syndrome. It was red, no fever, no real inflammation, but redness and painful. And we were treating them with corticosteroid. So we began to study this. And what we found in this red breast syndrome, that we had also a huge load of bacteria. So it was not logical for us to treat them with corticosteroid. And we began to remove those patients, to clean the implant and to change the implant when we had the red breast syndrome in front of ADM. And in all the patients that we had with red breast syndrome, we were able to find real cluster of bacteria on the ADM side. So for us, it was a bacterial problem, and we published this again in the PRS. We published our protocol. The red breast syndrome, when it happens, we going back to the OR, we're removing the implant, we're cleaning with VersaJet the alloderm, and we're putting back a new implant, a smooth implant. So this is the way we're treating it. And since we changed our paradigm, we were able to save several of these breast reconstructions. So the question is, and I have 15 minutes left, if it's okay, Dr. Mayer.
Yes, no problem.
So did we miss something? And this was always my obsession, because I really did a lot of job for Allergan. And I was not feeling well, because I promoted for years the macrotexture implant. So what with one of the former fellows that I had, to go back to the patent, to go back to the introduction of the macrotexture implant on the market. And what we found is that this introduction of macrotexture implant, and in this patent, so in the first patent, back in the 60s, 65, 63, 72, they almost describe everything. And the main goal of microtexture implant was never to reduce capsular contracture, but was always to have a stability. So what I thought I discovered in 2000 was already in the patent. Recording in progress. I found in a patent in 72, then in 92, this scheme that was published by Dubrut and Maxwell in the patent of BioCell. And you can see exactly what I described, the ingrowth of capsule tissue in the prothèse. So we knew everything. We knew that microtexture implant was all about stability. But the problem came when we began to have good results also on capsular contracture, and when all the advertising on the company went on capsular contracture prevention, and they didn't insist on the fact that to get this ingrowth in the tissue, the 70, that you need time to have the tissue ingrow in the pore. So you cannot put an implant and have movement immediately. You need to stabilize the implant for a while, and then you will have the ingrow in the pore, and then you will have a good stability. And this would have prevented a lot of the problem that we had. So we had a red flag, but we had no advice on how to prevent contamination and how to promote the ingrowth in the pore. So it was not, and now in North America, in Canada, we had to ban and to eliminate the microtexture implant, although I believe it was a huge addition to the armamentarium that we had, because with the microtexture implant, we were and I think because we didn't use it properly, because we were not trained to use it properly, we didn't have the full potential of this material, and this material had to be eliminated. So what is next? What is next? What is the next thing that we are missing? When we had to call back, when the BIA LCL came, we had to call back more than 1,000 patients from our service to see her and to be sure that they have not double capsule late seroma and BIA LCL ultimately. Thank God, when we call all those patients, we have no case of BIA. What we found is a huge amount of patients having pain with those implants, having pain with implant in general. And this was a surprise for all of us, because we were sure that this was a very stable material that we knew. And we began to shift the work of my lab on a particle theory, because we worked for years on bacteria, on the bacterial load, on biofilm. And then we shift, and we wanted to know what kind of particle was in the capsule to create such an inflammation. And should it be a cause of those chronic pain in patients that we had? You have the bleeding, and you have the particle from the shell itself. The confusing thing, we wanted to understand exactly what kind of product is in that silicone, and it is really in the implant, and we were not able. It's a very confusing information to get. You have a list of more than 40 components in that silicone, and all those components are very difficult to isolate. So you have the component that we know, the polymerized siloxane, but you have a huge amount of components that we are not aware of. And even from the company, it was very difficult to get this information. So back to the analysis of the capsule. Yes, we had two different type of silicon particle, the bleeding ones from 60 to 100 micron, and the shell, the particle from the shell that can be big, that can be up to 1 millimeter. And they're all in the breast capsule. So in our first paper we published with Caroline Glicksman from Massachusetts, we were just publishing that we think it's a thing that we must have in mind, that the amount of particle that we have in the capsule is not nothing. It's probably between 2,000 and 10,000 particles. And this particle can be up to 1 millimeter. So it's not nothing, but I was not happy with those results, and we continue to work on it. The particle from the shell, you're creating an impossible phagocytosis. So the macrophage and the giant cell are going around the silicone, but they're not able to dissolve the silicone. So in the end, it's exploding again in the capsule, and there is more silicone diffusing inside the capsule. So it's a kind of impossible phagocytosis. And I was not sure about the number that we had with Caroline Glicksman. I was not sure that it was only 2,000, between 2 and 10,000. So what we began to study is how big is this reaction? How big is the amount of silicone that we have in the capsule? So we began to study all those patients that came back after the BIL ALCL scandal and that wanted to have en bloc resection. So we did the en bloc resection for those patients, and we studied to count, to have a real count on the silicone particle that we had inside the capsule. So we took the capsule, we took different parts of the capsule, and we began to establish a method to identify the silicone and to separate the silicone from the fat that we have in the capsule. So it was visible in clear space with refractile, variable size, and often surrounded by giant cells. So we had the recipe to count all these particles, to measure it and to count. And thanks to one of my students, master student, Melvin, he did this counting. It was a very long job. It took very long time, but finally we were able to get a number, and we were able to correlate this number with the size of the implant. And it was between, for an implant of 300 cc, it's probably about 500,000 particles. But for an implant of 500 cc, it's more than 2 million particles that are in the capsule. So you can imagine the amount of inflammation it can cause. And we are only at the beginning of this. Can we accept to let those patients with this amount of inflammation, or we will work with the companies to find a way to reduce the amount of particles that we have in the capsule? So this is for me really the next question. And I think we shouldn't underestimate the amount of inflammation that we can create with with um, with our breast implant. We are seeing in research only what we are used to see, and we always have to move and have to shift the lens in the other direction to have another perspective. So this is what we are trying to do, and and I wanted to really thank all the team that I have, all the fellows, all the students, all the master students, all the fundamental researchers that we have, and including Dr. Diacon that was part of some sampling, um, harvesting, and some part of this job. So thank you for your attention, and I'm ready for question if you.
Thank you very much, Alain, for such a wonderful presentation, a very comprehensive review of all your previous work. And I have some questions for you and also those people from the audience who want to ask some question can send it through the chat, and I will be happy to ask Alain any doubt you might have.
Can you? Yeah.
Yes.
I didn't hear your last sentence. Sorry, Horacio.
Yeah, no, people can send they question.
Okay.
Chat.
Okay. Okay.
Okay, I would like to ask you regarding your theory about the infectologic origin of the red breast syndrome. I think that, as you said, it totally makes sense. I would like to know if you noticed, because we all know that we don't have ADMs in Argentina, but we all know that at the beginning, all the ADM were providing as aseptic ADMs. And nowadays, because of the high rate of infection, they move to produce a sterile ADM. Do you think that by using a sterile ADM might reduce the incidence of red breast syndrome if you consider as a real infectologic origin of this syndrome?
Thank you for the question. Yeah, we did this move also. So we moved to sterile ADM. I'm not sure, because when we study the bacterial load on red breast syndrome and on the ADM infection, they are all the same kind of bacteria coming from the skin, from the human skin, and from the skin of the mostly of the patient. So I really think the bacterial load is coming from the insertion of the implant. And even if we are mastering avoiding this, we cannot prevent having a certain amount of bacterial load. So this is our main hypothesis. We are not sure in my lab that the sterile ADM is changing a lot, and we don't see a lot of change. We still have those problems, and and I don't know if you know Anandiva from Australia.
Yeah.
Published with Bill Adams a very interesting study explaining the 14th step putting an implant, and all those 14 steps, it's all about covering the nipples, covering the skin, using iodine, and using a funnel, and preventing every contact. So it's all about preventing the insertion of bacteria. So this is really what we are focusing on, and this is what I think.
Great. Thank you for your answer, Ellen. I have another question. regarding, I know that you in Canada, I mean, all the public system in Canada, they are using just smooth implants, smooth expanders and a smooth implant from implant-based breast reconstruction. So I would like to ask you if you are noticing an increase of capsular contracture rates among your patients by not using texture device anymore?
No, we are not using, we are using micro texture device. So we are using still
Okay.
Siltex. We are using other device. But as I told you, I strongly believe that there is no difference in my hands between a micro texture device and a smooth device. So we are not using that. What is true, we cannot use any shape implant anymore because all those implants are turning upside down. So we are not using, so it's a huge loss for us because even for the stability, when we are using expander, it's very difficult for us to get stability. So even with the tag, the suture tag, the implant is still moving more than a biocell implant. So for us, the ban of microtexture implant is a problem, is a clinical problem, but no.
Yes, yes, we lose the connection a little bit. And do you think that, thank you, Alain, very enlightening. Another related question is that you mentioned the suture tab for expanders. Do you think that there is a company that is offering shape implants with suture tabs? Do you think that they could be a solution for, I mean, in the case of, for instance, FDA is always considering the possibility to ban any kind of texture, and you know, if you consider that possible scenario, do you think that the shape implant with suture tabs could be a solution, at least in part?
Well, what I can tell you is when we're using suture tabs with expand, and the implant is always free in the pocket. So when we are going back to remove the expander is always free. So it's not working. And all I'm keep telling that there is no stability with the suture tag. It can be temporary, but if you have nothing else that would replace this temporary stability, nothing else like Velcro or something like that, it will move. So every time we're going back, we're looking at the suture tab, and every time we're seeing that the suture tab are destroyed. So I am not a believer that we could have safe shape implant with suture tab.
Okay, thank you. We have some questions from the audience. We have one question from Professor Seaman here in Buenos Aires. He's asking, he's curious about if you studied smooth versus texture implant and the percentage of silicone in capsules from smooth and texture, comparing them.
I didn't have the end of the question. Can you repeat?
Professor Seaman wants to know if you were able to study the percentage of silicone in capsules from smooth and texture implants.
Yeah, it's thank you, Professor Seaman. It's a very interesting. We are doing that. So I included in the presentation some unpublished data about the number of silicone thing. So we are establishing 4 groups actually. The group of the group of macro texture implant with gel, the group of microtexture implant with water, and we will also have a group of smooth implant with gel and smooth implant with water fill. So we don't have this result because most of the patients we operate on so far were macrotexture implant with gel. So I just shared with you, this is an unpublished data. So yes, this is the next step. We want to know if all this silicone is coming from the shape of the from the texture of the gel.
Thank you, Alan. We have another question from Dr. Piedrabuena from my department. He wants to know if which are your recommendations for the follow-up of patients, of asymptomatic patients that that actually they underwent breast augmentation with microtexture implants.
So I think what is interesting, we had really some clusters about BIA LCL. It didn't happen everywhere. I did a conference in Australia, and they have, in the hospital I went, they had 25 BIA LCL. I did the same conference in Strasbourg in France. It's a small city. It's a small town of 200,000. They had 20 cases of BIA LCL. In our big center here, I recall nearly 2,000 patients, and I had no BIA LCL. BIA LCL in your patient, I think you should recall all those patients and establish a plan. At least teach them how to recognize the late seroma, or to recognize the first symptoms. But if you have no case at all, what we did in the SHIM, we connected with all our patients, and we established a nurse who was trained to do the information of all those patients, so they are able to auto-diagnose themselves.
And Alan, for reconstructive purposes, you continue to use microtexture devices. What about in your for cosmetic cases of breast augmentation? Are you continue to use microtexture, or you move to smooth implants?
I moved to smooth implants, and most of my colleagues moved to smooth implants because there is too much pressure. We have the group of patients also that are very active. Will the patient follow the surgeon or their Facebook group? And the answer, they will follow their Facebook group. They won't follow your advice. So we had two groups of patients. Patients were in the Facebook group, were following what the group was telling them. Even if we're telling them to not remove the implant and just follow, they were following, I want my implant removed. So in those conditions, we are not putting, we are putting only smooth implant. Most of the aesthetic surgeons in Canada are putting smooth implant right now.
Perfect. And there is another question also from the audience. Dr. Mendoza Santos would like to know if, what do you think about the electrostatic charges of that are produced during the manufacturing of the implant, and some surgeons that they irrigate the implant before placing in the pocket in order to neutralize these charges. Do you think that that makes sense? Do you think it's a good strategy to reduce contamination?
Can you hear me? Can you
Yes,
hear me?
yes.
Hello?
Did you hear the question?
Yeah. We didn't study. Yeah, I heard the question. We didn't study this specific aspect of electromagnetic field. I know that there are people working on it. Um, I don't have answer. It's not my expertise. What I know is that we don't know any. We don't know all that we are going through when we're putting an implant. That's for sure. And only the simple question, if a patient asks you, what is the real composition of the implant? We are not able to give this answer. We are not able to give a straight answer to the patient. There is so much component in those silicone, and it's so much different between a company and another that we are not able to give this answer. So yes, it's possible that there are other aspects of the problem, but I didn't personally study this, so I cannot answer.
Okay, thank you, Alain. There is another question also related to an alternative implant that two doctors, Dr. Orlando Silva and Dr. Joseph Borgi, would like to know what do you think about polyurethane implants? We all know that they are banned in the US. I don't know which is the situation in Canada, but do you think that they are a valid alternative to microstructure, or they are even a worse solution?
Sorry, can you repeat the first part of the question?
Yeah,
Sorry.
two doctors, they are asking about the polyurethane implants.
Okay.
Do you think that they are a good alternative? Do you think that they are a worse solution? What do you
You
think?
know, one day I was in a congress and I was speaking about this, and one guy shouted at me. He was, I think it's worst. In my opinion, polyurethane implant is a super macro texture implant, super macro texture. So all the phenomenon that we have is probably all the inflammation, all the potential bacterial load. As in my opinion, if you don't let the ingrowth of tissue completely in those pores, for me, it's not a good alternative. If we are banning macrotexture implant, let's say that polyurethane is a super macrotexture implant, in my opinion. So I won't go there.
Okay, perfect. And there is another question uh, about which is your current protocol, for placing an implant, whether for reconstructive or for aesthetic augmentation. I mean, you
Yes.
mentioned that word from Anandeva and Bill Evans about the 14 steps. Which one, which are your protocol? I mean, which of those steps do you think is might following? I mean, it's
Oh, I really think you should avoid going through the areola. So this is the first step. The areola is probably the most contaminated part of the human body. So you should not incise the areola. You should protect the areola. So you should put a shield, a tegaderm on the areola to protect it. And then I think in those steps, using of the funnel is probably a very interesting step. So avoiding the contact between the skin and the implant, and of course changing gloves, having a clean instrument. So there is a ritual. When I'm doing implant, and Diego can testify, we are changing all gloves. The nurse is changing gloves. Implant, and we need to have this kind of rules. So I would. Did you hear me or did it
Yeah,
cut?
I can hear you.
Okay, so yeah, the rule: change your instruments, change your gloves, protect the skin, use proviodine, and be as close as you can from the from the from the orthopedic protocol when orthopedic surgeons are putting implants.
Great. And when performing breast augmentation for cosmetic purposes, do you drain? Do you place drains?
No, I never place drain. Never, never. It's another source of contamination, in my opinion. I know that some believe that removing all the blood is also preventing the infection, but I do a very strong hemostasis and I don't put drain.
Okay. Well, we are almost on time. Alan, it's been a very enlightening conference. We all learned a lot from you today. I would like to thank you once again for your wonderful teaching work at the tomb in Montreal. We are gonna be for always grateful to you for having training Diego. That is our main microsurgeon here in our department. So we hope to have you in Buenos Aires soon, especially after you know that you are a huge fan of Guillermo Vilas and Diego Maradona. So we love you to have you here. I think that soon, once the pandemic is over, we'll have the opportunity to invite you to come to our hospital and perhaps visiting our hospital and performing some surgeries perhaps. So thank you again. I really like, I hope, are you going to Atlanta next month?
No, I'm not going to. Travel is still very difficult for us in Canada. So I'm not going, I'm going to Europe and not going to Atlanta. Travel to US is still difficult for us.
Difficult. Okay. Well,
thank you very much.
Okay.
And I know that you have surgery today.
Yeah, I have a flap. I have a free flap, Diego.
Wonderful.
Bye. Thank you. Thank you for the invitation.
Thank
Bye.
You
Thank you.
Bye.